All right, everyone. Welcome back to the WebbMD Podcast. Today I got one of my buds with me, Dr. Bradley. Welcome to the WebbMD Podcast, man.
Appreciate you bringing me on. It's an incredible space, beautiful podcast studio you got here.
Appreciate it. And welcome to San Antonio, Texas. You came out here actually at a really good time. The weather was pretty terrible the last few weeks and kind of clearing up today. So
yeah, it's beautiful. It's been beautiful out.
Yeah, good, man. So, Dr. Bradley, man, look forward to hearing about your story and your path to anesthesiology, as well as all the kind of things that you've been doing. I mean, I've been following you online and just inspired by you, man, especially for your passion for music and medical ethics and the Black Doctor Podcast, which I was on a episode of that. So I actually put that in the description as well. But you can just introduce yourself to the folks, let them know who you are and kind of what you do.
Yeah, I appreciate you bringing me on. I have a copy of your book on my shelf at home. I've definitely been an inspiration. I'm Dr. Stephen Bradley.
Yep.
I'm a critical care anesthesiologist.
Yep.
So I'm double board certified to do both anesthesiology as well as critical care medicine. I also am certified as a hospital ethics consultant. I do a lot of work in the bioethics space. Outside of medicine, I enjoy music. Mm-hmm. So I love to play different instruments. Kind of one of my hobbies is collecting random instruments. So I have a collection of synthesizers and weird stuff like the Suzuki Omnichord or the Teenage Engineering OP1 Field, which you'll see little gameplay.
I have no idea what those things are.
So I'm going to nerd out, but that's my kind of side passion in addition to medicine. Yeah,
excellent, man. So tell us a little bit about your background. Growing up, did you always know that you wanted to be a physician, anesthesiologist, or that kind of evolved over time?
Yeah, definitely evolved over time because growing up, I was a Navy brat. My dad was in the United States Navy, and we moved up and down the East Coast. I really enjoyed music. I started taking piano lessons when I was 10 or 11 years old. And at that point, my goal was to follow my father's footsteps into the service, but as a chaplain, but I could be like a music pastor. So I kind of combined everything I wanted. And when I started college, I was studying music. So that first year, I enjoyed it, but I realized I really wasn't applying myself. And one of my buddies, who's a music major, he made the jump into pre-med. I remember when he told me he did this, I said, my first words were, why would you do that? It's hard.
Yep.
And that resonated with me because I'm like, why am I in college? You know, my parents sacrificed so much to put me through college. And I'm saying, don't do this because it's hard. So that kind of helped the gears start to turn to think about what's the hardest thing I can do. What's a challenge that I can pursue? And I ended up switching to the pre-medical coursework.
So your initial degree was music, kind of on the music track?
Yeah.
Okay. So did you get a degree in music or just kind of switched to pre-medicine?
No, just did a year. I was, playing piano. I really enjoyed it. Actually conducted, take classes in conducting. So leading groups. I don't sing at all. So one of the big sticking points was voice lessons where I had to take solo voice lessons and sing alone. And I'm like, I definitely don't want to do that. But after that first year, I changed majors and continued on to medicine.
Oh, awesome. Yeah, I mean, that's a big misconception that I hear from a lot of students that they think they have to major in, biology, chemistry, whatever subject, but you could have majored in music and then still went to med school.
Yeah, it'd been a little harder road, or longer rather, getting all the prerequisites, but to be transparent, my degree is actually in pre-physical therapy because when I made that choice to change majors, I wasn't entirely sure that I had what it takes to get into medical school.
Yep.
I wouldn't say it was self-doubt, but more realism. And for me, I always want to have a plan B. I'm one of these people that I need options. So I figured I'll study pre-physical therapy. I'll take all of the prerequisites, like you mentioned, to be able to apply to medical school. But if that doesn't work out, then I can go into pre-physical therapy. They were just starting their doctorate program at the time. So I graduated with a degree in pre-physical therapy, but had all the prerequisites to continue on to medical school.
Yeah, that's pretty smart. I did something similar, kind of nursing field. Got my LVN license and kind of used that as a springboard and backup plan. I think it's real good to always have a backup plan. And if you can knock out 2 majors or knock out 2 disciplines in 1 major, I think that's kind of the way to go for students that are out there. So you ended up going to medical school at University of Florida?
We were in DC together. I was at Howard.
That's right. That's right. Yeah. Okay. Yeah. And how was your time in Howard?
Man, how much time do you have? we had a great time. As you know, the DMV was an incredible place. This is right around the time of President Obama's second term in office. Chocolate City, plenty of times on U Street. Yeah. If we had the money, we go down to Georgetown. We usually priced out of there, but and Howard University is just such a family environment. Yep. It's an HBCU, going up on the hill, homecoming, just so many incredible memories, and being surrounded by excellence, and excellence that looks like me. It was an awesome experience. Yeah,
definitely. It's always good to see people that are in similar situations heading down the same path as you and kind of encourage you to keep going down that path. I think that's extremely important. I didn't have much of that at Georgetown, but we had a few of us sprinkling around there.
Dr. Vanita Simpson, I think, was
correct. Yeah, she's the neurosurgery gurus. Yeah, I was just with her probably about 2 or 3 months ago out in DC. So and then you did residency, University of Chicago?
Yep, University of Chicago for anesthesia residency and eventually my critical care fellowship.
Gotcha. And what about anesthesia that kind of drew you to it? Why did you choose anesthesia?
Yeah, so as a medical student, I didn't know what I wanted to do. I got through the first 2 years and my goal was just to get into medicine. When I went to medical school, I didn't even know that there were really any medical specialties. And so it was a culture shock. Finishing up that first semester, I'm like, I made it. I've accomplished my goals. Where do I go from here? I think I actually wanted to do orthopedic surgery, actually, in retrospect. That was the only specialty I really knew about because as a pre-physical therapy major, I had shadowed some physical therapists and orthopedic surgeons. The great Dr. James Andrews. I was at the Andrews Institute down there. I'm like, this is cool. Orthopedic surgery, it's what I want to do. Then I showed up at Howard and I see all the ortho students studying from day one. They were in the boats. I'm like, whoa! I've already missed the boat. They're already getting their rotations in order, like they're shadowing. I said, that's not for me, but I don't know what is. So I waited until third year when I was doing my rotations. I figured, I'll see what everything's about. I had a buddy who was really gung ho about anesthesia. I said, I'll make that a plan B. At the time, and I just would go through and see what I liked. I really liked surgery. I liked working in the ICU. So I was going to be a trauma surgeon to be an ICU physician. And Dr. Wendy Green was my attending at the time. And we talked one afternoon on call. And she explained that to get to critical care medicine, you can go through different specialties. Internal medicine, you can do surgery, you can do anesthesia, and you can do pediatrics even. And so that kind of married the two things that I liked, anesthesiology and critical care medicine.
Yeah, and so I'm pretty sure being in Chicago, your training there was probably, you probably saw a lot of crazy stuff.
Yeah, University of Chicago was a phenomenal place to train. I went there because their ICUs are out of this world. Their anesthesia department really focuses on critical care, and their anesthesiologists are actively involved in the ICUs there. My first couple of years were, incredible surgeries, transplants. We actually didn't become a trauma center again. There's a lot of history there in Chicago, but my last year residency, we restarted the trauma center. And it wasn't until coming back for my ICU fellowship that I was really invested in the trauma program and the incredible amount of lives that they're saving on the south side of Chicago. It's phenomenal.
Yeah. What was the most challenging part of residency for you? Because a lot of people don't really realize that as surgeons, when we're at the hospital, you guys have to be there as well. So if it's, if we have an emergent case at 2:00 in the morning, an anesthesiologist has to be there to put that patient to sleep. So what was the most challenging part for you?
Yeah, the most challenging part of residency for me was a lot of the ethical dilemmas that I would come into contact with. I think back to, we saw some crazy cases, patients that would end up with heart transplants or on artificial hearts. And there were some ethical dilemmas there about these patients aren't necessarily candidates for transplant. So they'll never leave the hospital, but we're still investing a lot of resources and we're still providing care. And it was a fantastic way to learn because the institution would not simply, quote unquote, pull the plug on these patients. We would really provide care until definitive decision was made, whether that was a bridge to transplant, whether a patient succumbed to their disease process before that happened. But it really got me thinking about how do we make these very complex ethical decisions, because it really does tie into healthcare. And as a Black person, as a Black physician, so many times we are not in the rooms, and these very benign ethics decisions ultimately decide what happens in somebody's life.
Yeah, I can imagine that very difficult decision to make and kind of process to undergo. Is that what inspired you to, what's your title, kind of medical ethics consultant? Is that?
Yeah. I'm,
okay.
Through the American Society of Bioethics and Humanities, I'm a certified healthcare ethics consultant. That and $1 will get you a bag of chips.
So explain to the viewers, what does that mean? You come in certain situations and there's two sides, and then you're the mediator. Is that kind of how it works?
It can be. So through the federal government and kind of the way hospitals are set up, there was recently, in the last 10 or 15 years, kind of mandates or strong recommendations that hospitals have these ethics consultation services. How we actually have these differs from facility to facility. And a lot of people kind of learn on the job. As medical students, we had at least a course on medical ethics. You learned about autonomy and beneficence and non-maleficence and justice. And it's for people that, I'm passionate about medical ethics. I want to be on this committee. And that's the standard for probably, I think the last time I looked at the number is 70 to 80% of medical ethics personnel learned on the job. I was fortunate that at University of Chicago, they had the McLean Center for Clinical Medical Ethics. It's an ethics fellowship program. And I was able to participate in the program during my last year residency. It was a month of didactics where we learned from parishioners, we learned from lawyers, from philosophers, from physicians from multiple specialties. And the cohort, it was about 20 of us, ranged from pediatricians to surgeons to, I was the only anesthesiologist. There was a physical therapist there. There's a couple of nurses. And over the year, we would really work together to tackle different ethical dilemmas. We would rotate through the ethics consultation service and discuss these. Once a week, we would meet on a Wednesday for 2 hours and discuss these ethical issues and what the plan forward was. So it was a formalized training process. I was able to rejoin that during my critical care fellowship. And then ultimately, I took an exam through the American Society of Bioethics and Humanities to be a certified healthcare ethics. I think it's about 5 to 7% of ethicists are certified through that organization.
Really? Wow, that's awesome. Congratulations, man. What kind of you have a memorable case or a patient that you had to make a decision on whether, I don't know, to pull the plug or let this patient die, let him live? Do you remember a case that really just stood out to you during your training?
Yeah. A lot of very complex cases. And for patient safety, I'll kind of merge some stories and locations and totally de-identify this because these ethical dilemmas become very specific if you were involved. But for an example of a case that was challenging would be, there's two states that are next to each other. A patient, a young woman's found down, they've lost consciousness, but they're pregnant. They're 10 or 12 weeks pregnant. So they come to your hospital. What do? The patient is still alive. The baby is still alive as well. And you have to decide as an ethics committee, how do you go forward from here? You bring into that the family members. The family members may be more religious leaning. It's a fetus, it's a baby, it's viable. There's all those concepts of abortion, maternal care. What do we do with the unborn? And then you bring into it, maybe the patient's not married, or maybe they had a common law spouse in the state that they're from, but they just crossed state lines. And the common law marriage laws are different depending on the state. The abortion laws are different. And technically, your state may allow for termination, and maybe the state they're from doesn't. And what do you do in that situation? Obviously, you follow kind of the state rules that you're in, but it leads complexity to these situations. And the busiest ethics consultation, and most hospitals will allow patients and their families to request these ethics consultations if you're in a dilemma or stuck in a very challenging case. But in a couple of these consultation meetings. I was there as an ethics fellow, which is nice because I disabuse myself of my training as an anesthesiologist in critical care. But like, I'm not there clinically. I'm there from an ethics perspective. But there was also ICU physician. There was also endocrinologist. There was maternal fetal medicine. There was obstetric anesthesiology. There was neurology. So there was almost like 7 or 8 different, very specialized individuals in this family meeting. And we're able to sit down. It probably lasted over an hour and discuss the path forward and what to do. And in some of these cases, the decision was made that we proceed with supportive care while the baby continues to develop. And in some of those cases, we actually resulted in a viable baby being birthed by a cesarean delivery. And in some of those cases, the mother recovered as well. So those are a glimpse into some of the complexities that we can deal with.
Yeah, that sounds very, very challenging, especially when there's life and death kind of situations. And how do you make those decisions? How do you deal with that personally? I mean, I'm pretty sure that's pretty stressful and also a lot of responsibility kind of on your plate to kind of come in and figure out all the details. And I'm pretty sure there's a lot of time involved with researching information regarding the case and et cetera. How do you deal with that?
Yeah, it's very humbling because every patient, we all have our own code of morals and ethics, and it helps me focus on what is important to you as a patient. It doesn't have to make sense to me. Taking care of Jehovah's Witness patients that refuse blood products, but will receive heart transplants or liver transplants. I've taken care of those patients, and your belief or your faith, it doesn't necessarily have to make sense to me. I just have to respect what it is that you believe in, respect your wishes, and provide the quality of care as best I can. And it's been very cathartic to me to understand the concepts of autonomy and beneficence and what that really means. How do I provide this within the construct of my hospital's rules and regulations, the state laws? Maybe you're a resident. What does your attending feel about this topic? How do you kind of make everybody happy? Nursing staff, and understand that a lot of people, due to lack of communication, may perceive things very differently. So one of the biggest things that I think I've been able to help out with is the concept of moral distress, which happens when you know what the right thing to do is, but you're unable to do it. You feel powerless. And that happens so often in healthcare. We need to do this, but my attending says this, or ortho's not coming in to do this case, or anesthesia just canceled the case because the patient ate 12 hours ago. All that moral distress, like I know what we need to do, but we can't do it. And sometimes there's some deeper issues at play, and sometimes it's simply communication to ensure and understand that we're all here for what's best for the patient.
Yeah, I definitely agree with that. How much of this do you do in kind of your day-to-day? Do you find yourself still in these situations, or are you mostly kind of doing the anesthesia critical care at this point?
Yeah, most of my day-to-day work is anesthesia critical care. It's varied depending on the institution that I'm at. When I was in the Navy, I was a member of their ethics committee, and actively we met maybe once, twice, or every 1 or 2 months. I worked on Guantanamo Bay for a month, kind of got to see things up close and personal, gave a medical ethics lecture there. I'm not currently actively engaged in ethics consultations clinically, but I do provide a lot of talks and a lot of lectures and guidance. And my partners know, and I have a lot of people that just hit me up like, hey, what would you do in this situation? And I'm able to help people kind of walk through their decision-making process. Yeah,
and you mentioned kind of real briefly that your Navy kind of experience. So you went to the Navy while you joined the Navy while you were in medical school?
I joined the Navy in residency.
Residency, yeah. Okay. And then you did, how many years did you end up doing in the Navy?
4 years.
4 years. So you worked as an anesthesiologist in the Navy?
Correct.
Yeah, well, you mentioned that your dad was in the Navy, and I believe your brother, Navy
my
also?
Still in the Navy, yeah.
I see. Okay, so that kind of inspired you to kind of go down that path as well.
Yeah.
Yeah, how was your time in the Navy, and would you do it again?
Oh, the time, I live my life without regrets.
Yeah.
I think everything happens for a reason. I had a great time in the Navy. Everything we do has pros and cons. If I did it again, I would probably do 3 years instead of the 4 would be the one change I would make.
Yeah. What did you take away from your time in the Navy that you can kind of use at this point as an anesthesiologist?
Yeah, I learned a lot about leadership, good, bad, and other. So many times, a lot of being a leader is communication. I remember very distinctly, I was pulled in to this huge group of people when the COVID-19 pandemic came about, because somebody in the health department decided it would be a great idea to send the hospital ships to these cities in America, New York, and I believe San Diego on the West Coast, send hospital ships to help care for COVID patients. And being active duty, realizing that these are just big talking points and headlines, because these hospital ships don't have isolation bays. The isolation bays were like 6 of our ICU beds behind, those like plastic strips in a walk-in freezer. That was the isolation capabilities of the ship.
Wow.
And I recall, from the military, as you know, the job is to get the mission done.
Yep.
So they started pulling in everybody that was attached to the ship. And I have a picture somewhere of us in the casualty receiving area, which is just a big open area on the ship. And we are stacked in there information. So we're about 6 inches apart from everybody. There's about 150, 200 of us. This is in the middle of social distancing when we didn't have enough masks. And everybody's like, why are we here? They pulled in neurosurgeons. They pulled in, I think, 9 or 10 anesthesiologists. They had our cardiac surgeon there. They had basically, you could tell this mission was, just to get everybody, put them on the boat and send them to New York. And I remember just the lack of communication where, hey, we're concerned too about leaving our family. We're concerned about being locked up on a ship where we can't social distance. We're going to be living 6 to a berth in officer berthing. Wow. Enlisted people you're in a big old room with probably 60 of you. And furthermore, how are we going to treat COVID patients on this ship? And, I probably asked too many questions because I was dismissed from that deployment and escorted off the ship. But that to me was a takeaway of leadership. And even in an uncertain situation, sometimes it's helpful to just say, hey, we don't really know what's about to happen, but these are the orders that we got. We're going to try to execute as best we can. But it was a total just oblivion. Like, we're just going to act like there's not a pandemic and follow these orders. That was very distressing to a lot of the crew. So leadership was one of the biggest takeaways from my time in the Navy.
Yeah, thanks for your service.
Thank you for your service as well.
And then you did a critical care fellowship, and then got off the military, and now you're in Florida as a staff anesthesiologist, critical care.
Yeah.
What is like a typical day for you at this point? 10 to 2, 10 to 3.
A long day. Come on. I'm trying to be home by lunch. No, it depends on if I'm in the ICU or in the OR during anesthesia. For my ICU time, I work 7 12-hour shifts when I'm on service in the ICU, and then that's followed by a week off. And when I'm in the operating room, it depends. If I'm on call, I may come in at noon and then stay till all the cases are done and come in overnight if needed. But typically, those days are about 6:45 to 3 to 4 o'clock in the afternoon doing anesthesia.
So life is good right now as a
life
staff.
is good. Life is good.
Yeah. And so you work 1 week in the ICU, and then 1 week as an anesthesiologist. You have a week off in between.
Typically, it'd be a week in the ICU, a week off, and then 2 weeks of anesthesia would be a typical month.
Wow, that's pretty sweet.
It's not bad.
Yeah, awesome. How do you deal with the sickest of the sickest? I mean, these patients that come to the ICU, gunshot wounds to the head, critically ill patients on the verge of death. How do you deal with that? I know it's pretty challenging to see on a day in and day out basis.
I love this question because I think it resonates with a lot of issues we have in medicine. That as physicians, as healthcare providers, we tend to internalize a lot of things. I compartmentalize very well, for better or worse, if you ask my wife. But I understand that I have practiced and studied and trained to provide the best medical care possible. Sometimes, unfortunately, the best medical care possible will not save that person's life. And I think if you lean too much into it and think that you alone have some sort of innate power to fix somebody's back pain, which you do a good job of, but sometimes it may not work. But as I'm trying to save lives in the ICU, sometimes even the best of therapies that we have to offer will not work. And it truly bothers me if I sit back and think I could have done this different. If I had got this intubation the first attempt, then maybe we could have spared or saved this person's life. Or if I'd recognized that they were going into sepsis a little earlier and started antibiotics, then maybe they would have had a different outcome. That's what bothers me. But if I know that I have done the best thing possible, I have asked the right questions. I say to my team all the time, because I ask very simple questions. I learned from my attendings at University of Chicago, some of the smartest people I ever met. Some of them would ask very simple questions. And it's just to get the team on the same page and realize that everybody has something to offer. So I asked myself, did I ask the right questions? Yep. Did I consult the right people? I'm not scared. Like, you wake somebody up in the middle of the night and they're angry. That's human nature. Yeah, nobody likes to be woke up at 1 a.m. But it's my job to do that. Did I do what needed to be done for this patient? Did I explain options to that patient, to that family member? Did I do all the things that I need to do as a physician? And sometimes you do all that stuff and they make a fantastic recovery. Yep. And sometimes, unfortunately, they succumb to their disease process. But I'm not God. Yeah. And that's what kind of helps me get through.
Yeah, and I do the same thing. And patients come in with severely degenerated backs, and it's been going on for 20, 30 years, and they want me to fix it. And they want to be walking, hey, doc, will I be able to touch my toes, or will I be able to go running? my next question after that is I usually ask them, can you do that now? So, I mean, we can only do what we're been gifted to do, and certainly through our education and training, but there's certain things that are just out of our control. And I'm pretty sure it's challenging and hard. I've never had to do this many times, but to tell a family member that their loved one have passed. Do you have to do that a lot working in ICU as an anesthesiologist?
Yeah, probably more frequently than you doing ACDFs, but it is a very difficult part of the job. But again, it's my role, something that I chose to do, and a lot of those difficult conversations you set up for that beforehand, because I've been present at bedside, because the family has seen me actively working and taking care of their loved ones, because they've seen me explain the disease process, and I've explained the likelihood that their loved one is going to pass away or to die. Oftentimes, and with that ethics training that I've had, getting everybody on the same page, setting realistic expectations. I tongue in cheek, I say beautiful deaths. Basically, in healthcare, we fear death so much that we feel like we failed in medicine. Not necessarily, because like I mentioned, people die. And when I'm able to help family members and loved ones understand that this person is coming to the end of their life, they'll be done with their suffering. You can have time, because I was very transparent and candid, to bring your family members in. Now you guys are all here at bedside. And it's one of the things that I wouldn't say I enjoy doing, but I enjoy having people there to peacefully say goodbye to their loved ones. So it's one of the things that I have seen these conversations go poorly. Yeah. One of the most frustrating things that you can ever imagine, that somebody's last minutes are just a catastrophe of misunderstandings and miscommunications. So it's one of the things that I find peace in, knowing that I can bring this closure to families.
Yeah, it definitely takes a special person to be able to do that, especially on a day in and day out, and be able to do it in a way.
It's not day in and day out. No, it doesn't happen that often.
Gotcha.
Maybe every couple of weeks, but.
Okay, got you. What do you enjoy most about being an anesthesiologist?
Man, being an anesthesiologist, I enjoy, like as I tell every patient before I go to surgery, my job is to keep you safe and comfortable during your surgical procedure. Yep. And when I meet patients in the preoperative area, people are nervous, people are scared, people are anxious because they're about to have surgery. And you can kind of tell that. And the running joke is, anesthesiologists don't talk to patients, they just put them to sleep. But we have a very limited window to build that patient's trust and rapport. And I can kind of sense that as I walk in, especially I don't look like your typical anesthesiologist. I've got my locks out, just luscious and flowing at 6:45 in the morning.
Yeah.
And people are a little off-put sometimes. And I have to very quickly build their trust. And I do that by focusing on the medicine, by answering their questions, making patients feel heard. One of the things I do for every patient or family member, I'll ask them, what do you do for work? And then I try to ask at least one, if not two, follow-up questions, just to make sure that they know that they're being heard, and their concerns will be appropriately dealt with. And seeing, hopefully, that anxiety start to melt away. That's kind of one of the favorite parts of the job when it happens. Usually, I'm able to get people nice and calm. If not, there's medication for that. And then seeing them on the other side with their pain adequately controlled is very, very rewarding. Yeah.
Do you get mistaken a lot when you go greet yourself to a patient and they may think you're housekeeping or
transport?
Yeah. Do you get that a lot?
Yeah. That just happened a couple weeks ago. Myself and my nurse practitioner, we're both Black, walked in and in the ICU, they're like, oh, hey, you're taking me down to X-ray. We're like,
yeah.
No, we're here to check you out.
Yeah. I mean, that happens more than you would know, but it happens quite a bit. And I've had that happen a lot in residency as well. But so you're in the operating room with the surgeon. I'm pretty sure you've had some crazy interactions over the years, maybe residency. I mean, I've had some pretty, I would say, abrasive attendings at times and throughout my training, which surgery residency, I mean, I expected that, so it's challenging. And but what were your experiences like that with working with surgeons, various surgeons, neurosurgeons, plastic surgeons? I would imagine CT surgeons are some of the interesting group of people.
One of my favorite, didn't happen to me, it was a colleague. And what you learn being in the OR is that things are really quiet. It's hard to hear. There's so many noises and beeps. So early on in your residency, it's hard to hear stuff. And my buddy was in the cardiac room, and the surgeon was working, and he's like, piss, piss, piss. And my buddy is like, what are you? Like,
who's he talking to?
Pee? Like what? So he dives under the bed, and he's checking the urine. Patients have a Foley catheter, and you can see how much urine. He thinks the surgeon's asking for, how much pee is in the Foley. And mind you, the surgeon looks to the head of the bed. You can't see the anesthesia resident there because he's under the table looking at the patient's Foley. And the surgeon yells, "Puffs, give puffs," which is, to ventilate the lungs because the chest is open and you need to bring the lung. And so my buddy was kind of caught with his pants down because he's messing around with the Foley catheter. I was fortunate so far. I've mostly dealt with pretty easygoing surgeons. For surgeons that are a little more abrasive or particular, and then there's people that aren't very nice. I really haven't dealt with too many surgeons that are just mean. I try to understand why surgeons are very particular. Dr. Gary is a trauma surgeon I trained under in Chicago. He's at University of Vermont, I believe now, and he would say, "Stop for a minute and assume that everyone's reasonable." And that has carried me on since intern year. So if a surgeon doesn't want a nerve block, why? Is it because, my partners are too slow during nerve blocks and it's a 45-minute case delay every time they want a nerve block? Is it because their blocks don't work? Is it because, you need to check the function after your surgery? Really stop and think, if the surgeon's worried about fluid management in the operating room or bleeding, what were those experiences that put them on high alert? And I try to identify that root cause and then use that to end around and build rapport. The second thing I do is when surgeons if there's a conflicting goal or interest between my job as anesthesiologist and the surgeon's job. For example, plastic surgery cases, they don't like a lot of vasoactive medication, blood pressure medication. There's rumors and weak research that shows that it may damage their flaps or their plastic surgery. But if the patient's blood pressure is low and there's other issues that are going to happen with the heart not getting enough oxygen or blood flow and the brain not getting enough oxygen or blood flow, can't pump the ANSF around, then I have to put my foot down and say, for the patient's safety, we need to either give some blood, give some fluids, or give some pressors. And as opposed to, and usually I'll just give the surgeon that option. We're doing one.
Yeah.
Pick one. We got to do it. Because again, we're there for the patient. And I understand the surgeon's concerned about this very long 8-hour surgery that they're doing. I'm also concerned about the patient's long-term health after this anesthetic. And we need to meet in the middle and do what's best for the patient.
Yeah, that's a good way to go about it. I always wanted to ask anesthesiologists this. I mean, we're in the case. We're working hard, using all these instruments, and I'm sweating. It's hot under these bright lights. And I look over at the anesthesiologist throughout the case, and he's kicked back, got his phone out, maybe got a magazine, just reading. What do you guys normally do back there? I know you're watching the patient. Is it on cruise control most of the case, and you just kind of relax for a few minutes? What do you guys normally do back there?
Well, based upon a recent skit that I saw you produce, as well as Dr. Glockenflecken, he does a lot of videos on this now. Yeah, it would appear that we're out there hanging out with Sudoku. It depends, first of all, on the institutional practice. As an anesthesiologist, a lot of places work in the anesthesia care team model with anesthesiologists as well as nurse anesthetists and anesthesiologist assistants, where we may be supervising 2, 3, or 4 rooms. So we may not actually be there. I'm trying to deflect blame on the anesthetist. No, I'm kidding. So it's a team effort, first of all. But whoever is in the room, we are actively monitoring and engaged in patient care. Anesthesia is kind of like flying a plane. Yeah. Takeoff and landing are 2 very stressful points in the process. Depending on the surgery, sometimes it's on cruise control. We say there's 2 types of vitals in anesthesia. There's train tracks, which are just 2 lines, which are the blood pressure. It's straight, nothing changes, or a roller coaster where it's just up and down, up and down. And again, depending on the surgery, some surgeries you're on your feet the whole time. There's a trauma case that comes in, you're actively resuscitating, placing lines, and monitoring the patient and treating. Sometimes, you can for sure sit down and, maybe your phone goes off and you check a text message. Maybe you need to check your email. Ideally, we, for the most part, are engaged in actively monitoring the patient because things can change. You also have to realize that a lot of what we do is auditory. And after working for 6, almost 7 years in the field, we're listening to the sound of the pulse oximeter. I can usually tell what the surgeon's doing because I hear the heart rate go up. If there's a area that the patient's not fully anesthetized or they're starting to feel a little stimulation, I can hear all these things. I hear the ventilator going off. A lot of the things we're doing is auditory. Ideally, most of our time is spent actually monitoring the patient, providing patient care. I don't do Sudoku or crossword puzzles. I remember even in residency, I could not study during, you think, oh, well, I'm actually studying anesthesia, so it's okay. I just couldn't do it because I cannot, it's hard for me to multitask. I can't focus on 2 things at once. And as I mentioned, I wanted to do surgery. So half the time I'm watching the surgery, but I do try to provide as much attention to the patients as possible when I'm in the operating room.
Good. That's excellent. I mean, you guys literally have the patients' lives in your hands, and I'm pretty sure that's a huge responsibility, and definitely something that is kind of much needed. We can't do our jobs without you guys. So, I mean, that's awesome. We got to have you guys there.
And if, you're concerned about patient safety, intraop, for all the surgeons out there, please feel free to ideally have a collegial back and forth conversation with your anesthesia team. Say, hey, we're getting some bleeding, or hey, everything's good, check in. And we should hopefully be able to have this back and forth communication.
Yeah. I've seen a lot of conversation regarding CRNAs, and I mean, online, they make it seem like CRNAs are going to take over the whole field of anesthesiology, and the jobs that are available for anesthesiologies are decreasing. What are your thoughts about the roles of CRNAs, and do you currently use them in your practice?
Yeah, in my practice, I work with nurse anesthetists as well as anesthesiologist assistants. The need for anesthesia in general is increasing. We're taking care of older patients, sicker patients. There's more surgical procedures being created and performed. So there's actually a shortage of anesthesia providers. Those are nurse anesthetists, anesthesiologist assistants, and anesthesiologists. Like I mentioned, most places in the United States practice under the anesthesia care team model, which is an anesthesiologist that supervises nurse anesthetists as well as anesthesiologist assistants, depending on the state. We work together as a team. I think a lot of times the internet kind of brings out the worst of everybody. I think there's a lot of drama recently because I think recently there was a attempt or a name change of nurse anesthesiologists. It was just in response to the physicians changing our names to physician anesthesiologists because patients didn't know anesthesiologists were physicians. But an anesthesiologist is a physician who has completed medical school and completed 4 years of anesthesia residency. And again, we're fortunate to work with nurse anesthetists as well as anesthesiologist assistants. We've all received our respective training and the respective examinations that go with that. And we're licensed and we're there to provide care for what's best for the patient.
Yeah, excellent. As a patient is waking up, I hear it all the time. I have patients that wake up and say crazy things and off the wall things. Well, what's the craziest thing you've heard a patient say as they were waking up from surgery?
Oh man, it wasn't necessarily what they said, is what they did. Because in the Navy, where I was stationed in Virginia, we were next to Dam Neck and Little Creek, which is like the Naval Special Warfare Hub. So we get a lot of special operators in. We get Navy SEALs, we get some Delta Force folks, even the Marines, those crazy guys. And we'd have to kind of screen for that beforehand, like, hey, are you good? You had some PTSD, or you been downrange, or what's going on? And I just remember there was a Delta Force helicopter crew chief who was also a bodybuilder. I mean, this guy's back was immaculate. Like it's like I think it's like a adult. Like his lats were just massive, and he had this tiny little waist. just it's like, geez, like this guy is a beast. And he had back surgery. And for some of these folks, like we really can't even lighten up the anesthesia all the way because they just wake up fighting and swinging. We'll actually wake them up under sedation. So for back is a spine surgery, right? So micro discectomy. So he's laying on his back on whatever that table is. It has the two humps.
The Wilson frame.
Yeah. So surgery is done. Everything's great. I actually have him on a propofol infusion at a low dose. It's sedation because he's not awake right now, right? We've stopped the anesthesia. He should be awake, but I'm actually physically giving him some sedation, so he's still asleep. So we go to roll him over to the OR stretcher. And it's like 4 of us, and he's not moving. Like what? So we start trying to. We look under the bed, and he's got a death grip on the Wilson table. Yeah. So he's not going anywhere. Like so, we got to give him more anesthesia to put him back to sleep, flip him over. So that was kind of one of the things that those guys do and make. I've had corpsmen hanging off their arms as they're waking up, and we're trying to hold them down and give them a little extra medication, but they definitely made us work.
Yeah, I bet, man. I've had quite a few of those patients that wake up pretty wild, and definitely some interesting times. As an anesthesiologist, you're busy working. You have a family. Congratulations on your little one recently. And then you're into music, I see. Tell us a little bit about that, and you have a project that's coming out.
Yeah, so it started back in the pandemic days. That's when I got back into music, and I got into music production. That kind of led to me starting the podcast, the Black Artist Podcast. Yeah. I really enjoy audio editing and really trying to get the best quality audio. And then that evolved into making music once again. So all of 2024, I started a Mindfulness Monday project, and every Monday I would post a 90-second clip on Instagram playing the handpan or piano or making some mindfulness music, singing bowls or a sound bath. And hopefully people enjoyed that. I think the 7 people that liked the videos, like 7 or 8 of y'all that really enjoyed it. My wife being one, and then I got like 5 family members. But the point of that was to drive me to create. Yep. And I had a task every week to set up microphones, to record, to do some post-production work, to do some videography work, and then publish it. And I started making longer and longer tracks. And the litmus test is my wife saying, she'd walk in the room like, "Oh, is that you?"
Yeah.
She's like, "Oh, I thought that was somebody else." I'm like, "Oh, all right, it's getting." She's like, "Oh, that sounds like music." So I've continued to kind of do this work, much like yourself on a smaller scale. You've been working and grinding for 10 plus years with social media and videos, and just my goal was to just keep producing and keep getting better. And you'd be surprised that people are watching you.
Yeah.
And my good friend, Dr. Bianca Bush, the college psychiatrist, she reached out in the fall and was like, "Hey, I'm working on a project. Would you mind, should you make some tracks for mindfulness? I need 10 tracks." So I was able to, actually, I had a task. I'm somebody that needs a goal, or I need somebody to be like, "Hey, I need this." So I threw myself into that. And from about October to January of 2025, October of 2024 into January, I finished up my first album.
Congratulations.
Thank you so much. Release date February 5th, so 2/5/25.
Okay.
And the project is entitled "Twice Daily Until Symptoms Resolve."
That's awesome, man. Where can people find on 2/5/25? Where can they find this project?
Yeah, they can find it on all the major streaming platforms, your Spotify, Apple Music. Eventually, I'll be putting it to YouTube as well, hopefully with some video graphics. And again, it's ambient music from the rap beef that happened last spring. I think I took the words to heart. I make music that pacifies you. Yeah. So the goal is to provide some relaxation, some de-stress, some anxiety relief. Maybe you can use it to study too. Maybe you can use it to sleep. But that's the purpose of this album and ambient music. I think so many people, especially with the folks and the kids I took care of in Chicago, victims of gun violence and gang violence. And it's like, you go online and you see people having these peaceful retreats and these, handpan and sound bowls and all that stuff helps with anxiety, but it's not available to all in our community. Gotcha. So some of this driver is to democratize this music as medicine, this sound healing, something that can help take the edge off, treat that anxiety, treat that stress.
Awesome, man. Definitely keep that up. That's much needed, and look forward to the release of the project. Where do you see anesthesiology kind of going in the next 5 to 10 years? Where's it going?
That's a good question. I think it's going to be the biggest driver of change in anesthesiology is probably going to be legislature. As insurance companies do funny things with our payment model. As a physician, I think you had some videos recently as well, how every year we just get reimbursed less and less and less.
You see that the same in anesthesia as well?
The same in anesthesia, except whereas you work for yourself, I work in a group, and a lot of this is sheltered. And a lot of it's for anesthesiologists where you may be independent or you may be in a group. Most often we're salaried or you're doing locums where it's an hourly rate. And so you're a little sheltered from the actual reimbursement side, but that's still there because the hospital is going to see, anesthesia salaries as a money loser. So something that we still have to advocate for. But recently, there was a push to decrease anesthesia reimbursements depending on the length of surgery. A couple of years ago, there was a push from the insurers to stop paying for anesthesia for cataract surgery. There was a push to stop paying for anesthesia for nerve injections and pain procedures. And so as anesthesiologists, we have to pivot to, if I'm a pain doc, how do I give this patient this epidural steroid injection or this procedure without anesthesia because it's not going to be reimbursed and I can't afford that, quote unquote. Or the ophthalmologist who as a group and worked with the American Society of Anesthesiologists pushed back and said, hey, our patients need anesthesia for cataract surgeries. So they were able to reverse that.
Yeah, it's going to be really interesting in terms of what happens. As each year as we progress, we get paid less and less as physicians, and the cost of everything is kind of going up. At some point, there has to be some type of give. You guys as employed may be a little bit more insulated from that, but I'm in private practice, and my employees are asking for more. The rent every year, everything goes up, but we get paid less and less. But
I think the other thing that you're seeing is anesthesia leaving the operating room. So going to these different private sites. I think all over the news you're seeing tattoo studios, right? They're hiring anesthesiologists. Well, I don't know who they're hiring, but they're doing anesthesia for these full body tattoos. And you're seeing this kind of spread, which unfortunately there was a recent influencer who passed away from a complication when getting anesthesia for a tattoo.
Yeah, definitely got to be careful with that. But Dr. Bradley, I appreciate you coming on to the WebbMD podcast. Inspiration, man. I wish I had a passion to play music and had that, energy to kind of do that and follow that path. I always wanted to at least dream about doing something like that. Just never tried it. But yeah, keep doing your thing, man. I'm watching you, and we're rooting from afar, man. Look forward to this upcoming release. Where can people find you? Tell us a little bit about your social media handles and all that.
Yeah, first of all, I'll get you a melodica. We can start your music journey.
Sounds good.
All right. People can find me on social media. Stephen Bradley MD is my Instagram account. I used to post more medicine stuff, and then I switched over to my music. So I kind of feel like those guys in the subway that are giving you your CD. Yeah. A lot of my music stuff that's there. You can check out those projects. Be one of the 7 or 8 people that like my music videos. There's the Black Doctors Podcast, which has been going on since 2020. We're pushing up on 5 years now. Yeah. And there's a Instagram page for that, as well as, available on wherever you get your podcasts at the Black Doctors Podcast. Those are the 2. And then my YouTube channel, ambient.rx, is where I post my mindfulness music.
Awesome. I'll make sure I put all of those links in the description. But thank you, Dr. Bradley. I appreciate you coming on to the WebbMD podcast.
Appreciate you having me.
All right. Everyone else, thank you for watching. Make sure you like, subscribe, and we'll see you on the next one.